Welcome back everyone. This is Dr. Aditya Sibi Chakravarti from Dr. Talks. Today we will be dealing with the second part of the discussion on potassium disorders, that is hyperkalemia. So what is this hyperkalemia? Two cases. First one will be a diabetic ketoacidosis and second one will be in CKD precipitation emergency. These are the two cases where we classically see hyperkalemia. Any CKD patient presenting with any sort of new onset heart blocks, there is usually, you have to think in terms of hyperkalemia. So first we'll be defining what is hyperkalemia. A serum potassium value of more than 5.5 milliequals per liter. More than 5.5 milliequals per liter is called as hyperkalemia, and values more than 6 are usually what we consider as significant hyperkalemia. This hyperkalemia may not be as prevalent as hypokalemia, but this hyperkalemia has got high mortality and morbidity, predominantly because of its problem on the cardiovascular system, especially the heart. So this is the definition of hyperkalemia. Before going, we'll start with the causes of hyperkalemia. So what are the reasons why the blood potassium levels raises more than 5.5? The most common cause is an renal failure. It can be a chronic kidney disease or an acute kidney injury. This is the most common reason for hyperkalemia. The second more common reasons will be an metabolic acidosis. Any conditions with acidosis, like diabetic ketoacidosis or alcoholic ketoacidosis, starvation ketoacidosis, any condition having a metabolic acidosis, it can present as hyperkalemia. Now, what is this pseudo-hyperkalemia? Pseudo-hyperkalemia literally means it is because of a faulty technique. When you apply too much of compression at the site of taking blood, the faulty techniques can cause pseudo-hyperkalemia, or it can be secondary to a raise in the WBC counts or the raise in the platelet counts. All these things are called as the pseudo-hyperkalemia. So this is a second most common cause. Then hyperkalemia secondary to decrease in the potassium excretion. So where the kidneys are the major site of renal metabolism, and potassium excretion is increased in cases of acute kidney injury, chronic kidney disease, in patients with hypoaldosteronism. This hypoaldosteronism can be because of any reason. It can be because of low renin, hyporeninemic hypoaldosteronism, or hypereninemic hypoaldosteronism, the problem with aldosterone. So what are the causes of this one, hyporeninemic aldosteronism, that is low renin, that can be secondary to diabetes, uncontrolled diabetes mellitus, or it can be because of beta blockers and drugs, or it can be secondary to drugs such as NSAIDs, which will decrease the prostaglandin and thereby renin production. All these three conditions will cause low renin and thereby low aldosteronism and thereby hypokalemia. And conditions like drugs like AC inhibitors, ARBs, angiotensin receptor blocker, drugs like heparin, these will cause hypereninemic hypoaldosteronism because they block a little later. Say this AC inhibitors, ARBs and heparin will cause hypereninemic hypoaldosteronism, thereby causing hypokalemia. So what are the other causes? Transcellular shift. As we already mentioned, the transcellular shift means there will be shift of potassium from within the cell to the outside of the cell. When does this potassium changes from within the cell to the outside of the cell? That occurs when there is DKA, the diabetic ketoacidosis. That uncontrolled sugars can cause this shift. Then acidosis, again that is present in DKA, can cause this transcellular shift from within the cell to the outside the cells. Then other conditions like Addison's disease, or conditions like pseudo-hypoaldosteronism, or renal tubular acidosis type 4. These are the other causes of hyperkalemia. So what are the other causes because of breakdown? That is increased cell lysis. As we already mentioned, potassium is a major intracellular cation. So any condition where there is rapid lysis of the cell can lead to release of more amount of potassium. So it can be seen in conditions like tumor lysis syndrome, rhabdomyolysis, and any patient with hemolysis, or blood loss, when the internal blood loss bleeding into soft tissues, they can also produce this hyperkalemia. So how does get hyperkalemia because of increased intake? This is very rare per se. Once the patient is having a good kidneys, the development of hyperkalemia is very rare because a good kidney can eliminate potassium whatsoever. But theoretically, the causes can be because of increased consumption of potassium-rich diet, more consumption of let's say a coconut juice, bananas, tomatoes. All these things can theoretically can cause hyperkalemia. So this is the most important cause of hyperkalemia, and the hyperkalemia, first thing should be come to your mind will be this AKA or CKD, this renal failure. Now, how does this hyperkalemia presents? Clinically, most of the cases of hyperkalemia will be asymptomatic. There won't be any symptoms that is specific for hyperkalemia. Usually, it will be more like a CKD patient developing bradycardia, patient who's on dialysis, let's say twice weekly dialysis. The day before the dialysis, the patient, especially in the evening, they will come with the complaints of bradycardia, hypotension. If you take an ECG, and ECG is what gives the idea of hyperkalemia. Symptoms can be because of muscle weakness. Muscle weakness predominantly the lower limbs, then trunks, then upper limb, face, respiratory muscle weakness, everything can be occurring. And other conditions will be some neuromuscular irritability like tingling, perioral tingling, and then trembling of the hands and feet. These things can be present. So ECG, let's draw an usual ECG. This is the PQRS and this is the T wave. So this is consider this is a normal ECG. The first sign that you will see in any hyperkalemia patient when the values are more than 6 will be tall T waves. This T wave will go for tall. This T wave will appear in this way. This is called as the tall T waves. This is the first and earliest sign of hyperkalemia, usually seen with values in 6 to 7. Then the other findings will be the flattening of P waves. Then 7 to 8 will have QRS widening. This P wave will become flat and you will develop all sorts of hot blocks. First degree, second degree, third degree hot blocks, everything will be possible. So flattening of P waves and QRS widening will be there. Then there will be fusion of this QRS and T waves. QRS and wide QRS will fuse with T waves to form what is called as the sine wave pattern. It will be seen in values more than 8 milliequals potassium, and values more than 9 will produce invariably produce ventricular tachycardia or ventricular fibrillation, or the patient can present as cardiac arrest. Anything is possible. So initially begins with a tall T wave, then we'll go for flattening of P wave, QRS widening, QRS and T wave merging to form the sine wave pattern, and then go for any ventricular arrhythmias, ventricular tachycardia or ventricular fibrillation. Anything is possible. So how do you diagnose hyperkalemia? Basically, first thing will be some history, predisposing history, an AKA or CKD or some renal problem. Basically, that will be present. Second one will have classical ECG findings and symptoms of bradyarrhythmia. This patient, you have to think of hyperkalemia. First thing you have to rule out in hyperkalemia is to do one renal function test. Do an RFT, look for the urea and creatinine. If they are normal or you rule out any AKA or CKD, that should be done first. Once you rule out AKA and CKD, then you have to go for rule out the transcellular shifts. Transcellular shift must be ruled out. That can be ruled out with the help of all this, any finding of ABG showing metabolic acidosis, or the patients going high sugar, blood sugar levels, diabetic ketoacidosis, plasma stone, that can be positive. Those things can be done. Then you have to go for the urine potassium, and you have to calculate the TTKG. And also you should rule out pseudo-hypokalemia. By doing pseudo-hyperkalemia, the WBC count and platelet count should be normal, and you have to repeat the potassium values, and it will only be a mild improvement. Okay, then urine potassium and TTKG. So what is this TTKG? TTKG is also called as the transtubular potassium gradient. This TTKG can be done with the help of urine potassium formula. This is the urine potassium by serum potassium into serum osmolality and urine osmolarity. This TTKG means is the function of aldosterone. To get hyperkalemia, the aldosterone should be functioning less. Hypoaldosteronism can cause hyperkalemia. On all this condition of extra renal loss, they will have increased urinary, when any hyperkalemia patient with the extra renal cause of hyperkalemia, the urine potassium excretion will be increased. The urine potassium excretion will be more than 80 milliequals, 60 to 80 milliequals per day, and the TTKG will be more than 10 in non-renal causes. In renal cause, however, you will find that the TTKG will be somewhere around 3 and the urine potassium excretion will be somewhere less than 15 milliequals. So this way you can identify whether this is an renal or non-renal cause of potassium excretion. Once you have done the TTKG is less than 8, you can diagnose this as hypoaldosteronism. Now, it is important to classify whether this hypoaldosteronism is a true hypoaldosteronism or pseudo hypoaldosteronism, for which you have to go for replacement with the fluorocortisone. Once if you give a fluorocortisone, which is actually a mineralocorticoid, this mineralocorticoid will go and act as in the distal convoluted tubule, causing potassium excretion for sodium reabsorption. Thereby, this will increase this if this normalizes the urine potassium excretion and TTKG, then that is called as the normalize the value after adding fluorocortisone. You have to think in terms of true hypoaldosteronism. If it does not, if it still remains elevated, if it does not becomes normal, then you have to think in terms of aldosterone resistance. As true hypoaldosteronism, then you have to measure the renin levels, and you can say low renin, low aldo, or high renin, low aldo. Aldosterone resistance, it can be either because of type 4 RTA, or it can be because of congenital pseudo hypoaldosteronism. These are congenital disorders. So this is the workup of potassium. So any patient presenting with high potassium values, first look for the R of T, rule out acute kidney injury or chronic kidney disease. Then you have to go rule out transcellular shift. Then you have to measure the urine potassium. Suppose if the urine potassium is increased, then you have to think of hypoaldosteronism. Then do a TTKG. If TTKG is found to be low, less than 8, you can confirm hypoaldosteronism. Then add fluorocortisone. If the hypoaldosteronism gets corrected, then think of in case of true hypoaldosteronism. Then true hypoaldosteronism can be classified into two groups. Those with low renin, low aldosteronism, or high renin, low aldosteronism. Low renin, low aldosteronism, as we mentioned earlier, will be a problem with the release of renin. That can be because of diabetes mellitus or beta blockers or NSAIDs. Or high renin, low aldosteronism, that can be secondary to conditions like heparin, AC inhibitors, ARBs, Addison's disease, all these conditions. Now, second group will be the aldosterone resistance, that can be because of type 4 RTA, or it can be because of other conditions like pseudo hypoaldosteronism. Now, how do you treat hyperkalemia? Hyperkalemia is a medical emergency and it should be picked up immediately after taking an ECG. A patient, CKD patient present with the casualty, present ECG, presenting with the heart block or some arrhythmia, some ventricular arrhythmias, you have to first think in terms of hyperkalemia, send the potassium. If it's found to be elevated, you should go for emergency management. A value more than 7 means emergency, value more than 6.5 itself means an emergency. First one will be the calcium gluconate. Calcium gluconate, this is given as an emergency drug. 10 ml, 10% over 10 minutes. and can be repeated till there is a normal ECG activity on the monitor, normal ECG monitor. After 30 minutes, it can be repeated. So 10 ml calcium gluconate, 10% over 10 minutes should be given. This calcium gluconate, what it does is that it protects the heart from this hyperkalemic adverse effect. This hyperkalemia goes and acts on the heart and will cause ventricular tachycardia and ventricular fibrillation. To protect this heart from this potassium overload, we give a calcium gluconate. It does not reduce the potassium levels, but it just protects the heart. Then we will go for steps to lower the potassium values. First, we will go for the GIC, the glucose insulin infusion. That will be in the 25% dextrose, 100 ml. You add a 10 units of regular insulin, 10 units of regular insulin. This should be given over a period of 1 hour. This will reduce the potassium levels by 1 milliequal. 1 milliequals per liter. Then the third one will be the sodium bicarb. Sodium bicarb. The sodium bicarb, that has got two problems. One, so in CKD patients, they will be already volume overloaded. When you give a sodium containing fluid as a sodium bicarbonate, this will worsen the volume overload and can cause problem because of volume overload. Secondly, the sodium bicarbonate can be given only if the conditions favor it. So suppose the diabetic ketoacidosis having a pH of less than 7 and a bicarb value of less than 10, then only you can go for the sodium bicarb replacement. And it should, first the bicarbonate deficient should be calculated, and then correction should be given. Around 100 milliequals correction is usually given for sodium. This can reduce the potassium level by 1 milliequals. Then the other one will be the resins, salbutamol nebulization. Not the usual dose of salbutamol. 20 ml of salbutamol is a quite high dose in 4 ml of saline, can be given by nebulization over 10 minutes. This salbutamol nebulization also reduces the potassium level by 1 milliequal per liter. Then potassium binding resins, sodium polystyrene sulfonate. This sodium polystyrene sulfonate will absorb potassium and will emit sodium in return, and this sodium potassium binding resins can have problems with the GIT, namely abdominal pain, constipation, vomiting, GI perforation. Those things are possible, so that is not that has to be K-Bein sachet that is commercially available. That is what we usually prefer. The other things that you can be doing for this patient is that dialysis. Of course, you can use a diuretics like loop diuretics, Lasix or thiazides, but dialysis, any patients with refractory hyperkalemia to medical management, dialysis is the treatment of choice. It can reduce the potassium by as much as 30 milliequals within an hour can be reduced, and dialysis is the definitive treatment for hyperkalemia. In non-emergency setting, once this emergency is overcome, then what are the other things you can do? The general preventive measures will be, in any case of hyperkalemia, once a patient is diagnosed with hyperkalemia, you have to be wary of putting the patient on ACE inhibitors, ARBs, heparins, potassium sparing diuretics, as all these drugs are known to cause hyperkalemia. Secondly, you can increase the dose of diuretics like loop diuretics and Lasix and thiazides to promote the potassium excretion. Then the patient can be advised to avoid potassium-rich diets like spinach, bananas, sugarcane water. Everything can be they can be advised to not use. Then specific management of the problem, say diabetic ketoacidosis, you have to go for insulin infusions, and for suppose the patient of Addison's disease, you have to go for steroid replacement. Melanocortin deficiency, you have to go for fluorocortisone replacement. Then specific etiology should be treated. Then metabolic acidosis, the patient can be started on soda bicarbonate, a 600 mg TDS can be given to revert the underlying acidosis. So this sums up our discussion of hyperkalemia and thereby the potassium disorders. I hope you like this discussion. If you like this discussion, I would like you to share this video with all your friends and help the channel grow. Please subscribe to my channel and let me know what your thoughts about this video are. Thank you.